Welcome to this Step 2 clinical knowledge review on common rashes and test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for dermatology rashes, and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the dermatology and immunology sections of first aid and your question bank before or alongside this video. Here is what we are covering today. We are going to focus on recognizing high-yield question stems for common rashes, applying test-taking strategies for eczema versus psoriasis, urticaria and angioedema, and drug eruptions. We will also master the next best step question format for these topics. Before or alongside this video, make sure you review the dermatology and immunology sections of first aid and your question bank. This video is about applying that knowledge strategically, not replacing it. Let us start with one of the most tested distinctions on the boards: eczema versus psoriasis. This comes up all the time, and the question stem will give you clear clues if you know what to look for. For eczema, think flexural distribution. The rash appears in the antecubital fossae, popliteal fossae, and neck. It is intensely pruritic with weeping, crusting, and lichenification in chronic cases. The key buzzword is atopy. If the patient has a history of asthma, allergic rhinitis, or a family history of atopic disease, think eczema. For psoriasis, think extensor surfaces. The rash appears on the elbows, knees, and scalp. Look for well-demarcated plaques with silvery white scale. Nail pitting and the Auspitz sign, which is pinpoint bleeding when the scale is removed, are classic differentiators. The boards love testing this distinction, so always check the distribution first. Now let us talk about urticaria versus angioedema. This is another high-yield comparison. Urticaria presents with pruritic, raised, well-circumscribed wheals that blanch with pressure and characteristically migrate within 24 hours. If you see a question where individual lesions persist longer than 24 hours, think urticarial vasculitis instead of simple urticaria. That is a common trick on the exam. For angioedema, look for deep, non-pitting swelling of the lips, tongue, or eyelids without pruritus. One of the most tested scenarios is angioedema associated with an angiotensin-converting enzyme inhibitor. The mechanism is bradykinin-mediated, not histamine-mediated, which is why antihistamines do not work well. The board answer is always to discontinue the medication. For hereditary angioedema, look for recurrent episodes without urticaria and low complement 4 levels. These are classic board findings. Let us review the high-yield question stems you need to recognize instantly. For eczema and psoriasis, the stem gives you a chronic, relapsing, pruritic rash. Check the distribution. Flexural means eczema. Extensor with silvery scale means psoriasis. For drug eruptions, look for a new medication started in the past 1 to 3 weeks, followed by a diffuse, morbilliform rash. The key escalation is mucosal involvement or skin sloughing, which should make you think Stevens-Johnson syndrome or toxic epidermal necrolysis. The percentage of body surface area detachment is what determines the diagnosis on the exam. For viral exanthems, look for a child with fever followed by a characteristic rash. Measles has cough, coryza, conjunctivitis, and COMLEX spots. Fifth disease has the classic slapped cheek appearance with a lace-like rash. Roseola has the rash appearing after the fever breaks. Matching the pattern to the virus is the key. Let us try a practice question. A 32-year-old woman presents with a 6-month history of an intensely pruritic rash on both arms. She has a history of childhood asthma and seasonal allergies. On exam, there are erythematous, lichenified plaques with excoriations in the bilateral antecubital fossae. What is the most likely diagnosis? Take a moment to think about this before we go through the answer together. Let us walk through this answer step by step. Step 1, spot the pattern. We have a pruritic rash in the flexural areas with a history of asthma and allergies. Lichenified plaques with excoriations tell us this is chronic. Step 2, apply the rule. The board rule is that atopic dermatitis equals flexural distribution plus pruritus plus atopic history. When you see these 3 elements together, atopic dermatitis is the answer. First-line treatment is emollients and topical corticosteroids. Step 3, eliminate the distractors. Psoriasis would present on extensor surfaces with silvery scale, not in the antecubital fossae. Contact dermatitis requires a clear exposure history and typically has a geometric distribution matching the contactant. Seborrheic dermatitis affects the scalp, nasolabial folds, and eyebrows. The correct answer is B, atopic dermatitis. Here is another practice question. A 55-year-old man presents to the emergency department with acute onset swelling of his lips and tongue that began 2 hours ago. He has no urticaria or pruritus. His medications include lisinopril, which was started 3 weeks ago, and metformin. He has no known drug allergies. What is the most appropriate next step in management? Think about what the key clue is in this stem. Let us break this one down. Read the question carefully. We have isolated angioedema without urticaria in a patient recently started on an angiotensin-converting enzyme inhibitor. The absence of urticaria is critical because it tells you this is not a typical histamine-mediated allergic reaction. This is bradykinin-mediated angioedema caused by the angiotensin-converting enzyme inhibitor. The definitive management is to discontinue the lisinopril. Epinephrine is for anaphylaxis, which would include urticaria, hypertension, or bronchospasm. Serum tryptase is useful for confirming mast cell activation, but does not change the acute management. Imaging of the neck is not needed unless there are signs of airway compromise. The correct answer is B, discontinue lisinopril. Now let us cover drug eruptions, specifically Stevens-Johnson syndrome and toxic epidermal necrolysis. These are among the highest yield dermatology topics on the boards. Stevens-Johnson syndrome involves less than 10% body surface area detachment. It presents with targetoid lesions and mucosal erosions after starting a new medication. The most commonly tested culprits are sulfonamides, anticonvulsants like carbamazepine and phenytoin, allopurinol, and antibiotics. The immediate first step is always to discontinue the offending drug. Toxic epidermal necrolysis involves greater than 30% body surface area detachment and carries high mortality. Between 10 and 30% is classified as overlap syndrome. Management includes transfer to a burn unit, fluid resuscitation, and wound care. The boards heavily test the percentage cutoffs, so remember, less than 10 is Stevens-Johnson syndrome, 10 to 30 is overlap, and greater than 30 is toxic epidermal necrolysis. Let us try another practice question. A 25-year-old woman presents with a painful rash and mouth sores that developed 5 days after starting a sulfonamide antibiotic. On exam, there are targetoid lesions on the trunk and extremities with blistering and epidermal detachment involving approximately 8% of her body surface area. She has erosions of the oral and conjunctival mucosa. What is the most likely diagnosis? Look for the key numbers and findings in this stem. Let us walk through this answer. Spot the classic pattern. A new sulfonamide antibiotic followed by targetoid lesions, mucosal erosions at 2 sites, and skin detachment involving less than 10% body surface area. This is the textbook presentation of Stevens-Johnson syndrome. Now know the key distinction. Erythema multiforme can have targetoid lesions, but typically lacks the extensive mucosal involvement and skin detachment. Toxic epidermal necrolysis requires greater than 30% body surface area detachment, and this patient only has 8%. Staphylococcal scalded skin syndrome is seen in young children and does not involve the mucosa. The correct answer is B, Stevens-Johnson syndrome. Here is a test-taking pearl on viral exanthems. The exam loves testing the sequence of symptoms and classic descriptors for each virus. Measles starts with cough, coryza, and conjunctivitis. Then COMLEX spots appear on the buccal mucosa, followed by a maculopapular rash spreading from the face downward. Rubella has a similar rash, but with postauricular lymphadenopathy. Fifth disease, caused by parvovirus, shows the classic slapped cheek appearance on the face, followed by a lace-like reticular rash on the body. Roseola presents with high fever for several days, and then a rash appears after the fever breaks. The key strategy is to always match the rash pattern to the associated findings. Measles with COMLEX spots, rubella with postauricular nodes, fifth disease with the slapped cheek rash, and roseola with the rash appearing after defervescence. These associations come up frequently and are considered among the most tested topics in dermatology. That wraps up our review of common rashes and test-taking strategies for your board exam. Remember to review the dermatology and immunology chapters in First Aid and your question bank. Focus on rash morphology, distribution patterns, drug reaction classifications, and viral exanthem associations. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help guide your preparation. If you found this video helpful, make sure to like and subscribe for more board review content. Good luck on your exam.